Hello, my name's Ian McCall. Let's have a little look at module Webinar 36. Animal scabies. Normally, if we're going to see it in Australia, we'll see it as being acquired from dogs, and it's particularly a problem in some Aboriginal communities. In fact, it's been said that if we don't get rid of scabies in animals in Aboriginal communities, we're really not going to get rid of streptococcal secondary infection and renal disease and a whole lot of other problems. So when you're treating scabies in an Aboriginal community, you've not only got to treat the humans, you've got to try and eliminate it from the animals as well. We've said that, how is it different? Well, in animal scabies, the face is often involved as well. And there are no real burrows that you can see. But the other thing is that it's a self-limiting condition. Because it's derived from an animal, our immune systems seem to be able to react to it much better than we do to ordinary scabies. And so it's self-limiting. The other condition you may see that looks like this is Shigella. Now again, Shigella is derived from cats and dogs. It's particularly seen as a scaly eruption around the nape of the neck. It's going to present in the owner as papular urticaria because there's a hypersensitivity, delayed type 4 reaction to the mite, and basically it's going to come up as a papular urticaria. And again, it's going to be in areas of contact with the animal. What about starling mites or bird mites? These you'll tend to see in summer months. They usually are in nests in the roofs. And if the mite comes out on a warm night when the window's open, then the mites can come in through the window and they'll tend to give a papular urticaria eruption on the exposed parts of that individual. And it can also be seen as an occupational hazard if someone accessing a loft area. And this is interesting. The lesions here are usually found at sites of pressure. I'm not sure if I can give you a good explanation of that. This, by the way, is a scabies mite, a very characteristic picture. You often won't see the mite itself. You may see some of the scabetic material, and certainly with a dermatoscope you should be able to see the scabetic burrow. What's the next topic? Blisters with erythematous papules. Blisters with erythematous papules. Well, you can argue that papules are a milder form of the inflammation that's taking place, and blisters occur when you've got maximum inflammatory damage. We've said that if it's symmetrical, consider dermatitis herpetiformis. Now that's your gluten hypersensitivity rash. Typically it's going to be seen on the elbows, symmetrically, on the scapulae, and on the buttock cheeks. Now we've also said vasculitis, where you may get blisters and erythematous papules. If you're going to get blisters, you're generally going to have palpable purpura as well if you're going to have vasculitis. So I think it'll be more than just red papules. And the other condition we've said is the id reaction, the autoexematization reaction with the dermatitis. Now sure, it's mainly vesicles you're going to get. Some of them may join up. You may get some itchy red papules as well, but generally there'll be some weeping. Remember the small superficial erosions that you're going to get in an eczema from the spongiosis. Now those were symmetrical blisters with red papules, and here if asymmetrical, consider pemphigoid, insect bites and scabies. All right, I'll go for the insect bites and scabies. That's usually asymmetrical. Bullous insect bites you're likely to get. They'll often occur without much of a red base sometimes. You're going to get them in people who are new to an area. Scabies, you'll certainly get the red papules. Blisters, not a common thing with scabies, but if you're going to see it, it's going to be in babies. And pemphigoid, they've said asymmetrical. I tend to think of pemphigoid really as an endogenous symmetrical disorder with blisters coming out of both groins or both axillae rather than on one side. But we might agree to differ on that one. Atypical types of erythema multiforme. What's the link? Global Skin Atlas. Let's have a look at it. What have we written there? Recurrent erythema multiforme. Well, if you see recurrent erythema multiforme, go looking for either a drug reaction or scabies, recurrent herpes. And then a variant with one extending or static lesion, a solitary lesion of erythema multiforme. Well, I tend to think it would be a fixed drug reaction if that was the case. Let's have a look at the link, see what the images are that we've got up for that one. Where are we? Here we go here. These are the various morphologies of patients with erythema multiforme. We typically think of it as giving target lesions, particularly acrally. But it's not called multiforme for nothing. You can get red patches with red papules superimposed on the area. There's a good example here of some of the acral target lesions that you can in fact get, where the blistering is occurring in the center here, and you have the surrounding erythema. But they are more typically seen on the lower limb in this condition. Okay. Parapsoriasis. We've said it's a term we don't use as much nowadays, but there is a variant that goes under the name of digitate dermatosis, and this is an example of it here. It's almost like zebra markings on the skin, and these plaques well, often they're just patches. They're not in fact thickened, and there may be some fine cigarette paper wrinkling on the surface of the skin over these. They may not be terribly itchy either. The big problem is, if you biopsy these, the early changes of T-cell lymphoma may not be present, and it may simply show a degree of mild spongiosis with an infiltrated lymphocytes into the epidermis. I mean, that's why you get the red, slightly scaly rash in the first place. Many of these remain like this for years and years and never really progress to plaques or to nodules. They'll often clear in the summer months with a bit of ultraviolet exposure. But I think it's, the problem is if you biopsy them early, it's going to come back as a chronic superficial dermatitis. But you can often diagnose this condition clinically better than the pathologist can. We've said here that they're usually well demarcated. Well demarcated lesions usually suggest malignancy, whereas dermatitis and the like is usually a very diffuse edge. There's another variant called large plaque parapsoriasis, and it's been said that type is more likely to go on and develop into a cutaneous T-cell lymphoma. It's thought that about 10% of cases will develop into a frank lymphoma, but as I said, there are many people who believe that all parapsoriasis represents a lymphoma of sorts. There's a retiform parapsoriasis, a reticulate variant. We've said almost 100% of these will develop full T-cell lymphoma of the skin. And then there's lymphomatoid papulosis, which I don't have a picture here, which looks totally different. About 15% of those patients will go on to develop a frank lymphoma of the skin. This is a CD30 positive tumor. Usually it's papule, it may develop a bit of necrosis centrally, and then mysteriously it just resolves in a 3 to 4 week period. There's a history of several of these coming up, then you can make that diagnosis. Carotid Irma. means thickening of keratin on the palms of the hands, soles of the foot, or at least palmoplantar keratoderma does. Now, some of these causes are congenital and some are acquired. But if you've got congenital keratodermas, then certainly look for the family history. Now, I think there's 20 to 30 of them that are named in the books. Some are autosomal dominant, some are autosomal recessive, and there's probably other inherited patterns as well. But in the acquired keratodermas, look at this carefully. We've said there, look between the toes to exclude a fungal infection, because occasionally, a severe fungal infection can present as a keratoderma. And said there, you may get crusting with a fungus. Now, if that's the case, then always consider crusted scabies. If you've got crusts on the palms of the hands or the soles of the feet, and especially if the patient's a bit itchy elsewhere and has other excoriated lesions, then consider crusted scabies as the cause of the keratoderma. It's made up of crusts rather than the layered keratin you'll get in the keratoderma. We said here with Diarrhea's disease, you can get pustules, and sometimes when you remove the scale, a little pit's left. With histiocytosis X, you get no pustules. But I must admit, histiocytosis X presenting as any type of keratoderma would be most unusual. Cicatricial pemphigoid, that's what this image is here. Now that's scarring mucosal pemphigoid. The damage is underneath the lamina lucida and the lamina densa, and the antigen that's attacked there gives rise to healing with scarring or blisters with scarring. Here you're getting involvement of the conjunctivae, and you're getting these synechiae or scars developing between the layers of the conjunctiva. And this can give rise to blindness. Now, as well as affecting this mucosal surface, in cicatricial pemphigoid, it can affect the inside of the mouth, it can affect the vulval areas as well. So if you've got unusual vulval ulceration, then you've got to consider cicatricial pemphigoid as your potential diagnosis. You can have IgG laid down, and often you can have IgA laid down. Now, the variants that have IgA laid down are more likely to respond to dapsone. Dapsone is the sulfone that's used both in leprosy and in dermatitis herpetiformis. But it can be very effective in this condition. It can also be used in some types of pemphigus. Now, cicatricial pemphigoid, we typically think of it as attacking mucosal surfaces, but sometimes the process will attack the scalp. Rarely that can happen, and it'll present as a scarring alopecia. You may just get those areas and not get the mucosal areas involved, but that must be rare. It's a rare condition. Raynauds phenomenon. Raynauds disease and Raynauds phenomenon. Usually seen in women. Raynauds is, by the way, is where the hands go white, the digits go white, and then subsequently they go blue, and they can be quite painful when they're white, and it's often a type of vasospasm that occurs particularly in very cold weather, or if you've got some underlying abnormality that's producing cryoproteins or cryoglutenins or some other underlying disease. Usually seen in women under the age of 40, often all the fingers are involved, but not always, it may just be some. Gangrene does not happen in Raynauds disease. In other words, the vasospasm is reversible, doesn't give rise to it. Paroxysmal nature of the process is important. Cold agglutinins, cold hemolysins, and cryoglobulins, they can all cause Raynauds, but cold fibrinolysins do not. God bless them. Now, if you've got Raynauds plus libido, you've got that curious net-like pattern, say on your limbs, then, or on your hands and arms, then there's usually a cryoprotein involved. Then we've got a mnemonic for the causes of Raynauds disease using the letters. R for Raynauds disease, A for autoimmune conditions such as lupus, scleroderma. That's the one where you're going to see it most. That's the one that comes to mind if you get a patient presenting with Raynauds. Dermatomyositis, mixed connective tissue disease, sure, it can occur with those. Y is for blood, or bloody, to remember the causes like cryos and cold agglutinins. N for neurovascular compression. Okay, what are we talking about there? The accessory rib syndrome, cervical rib syndrome. I think that can do it. N for neoplasms. Must admit, don't normally think of that. A for arterioles or arterial disease, such as Berger's and atherosclerosis and arteritis. U for udonate. Typewriter or keyboard nowadays. Pianos, vibration-induced Raynauds, vinyl chloride induced PVC, polyvinyl chloride exposure causing Raynauds. And then some drugs. There are always drugs. Ergotamine used to be used for migraines as a vasoconstrictor. You can acquire it from certain plants. Methysergide. I don't think we've got that around anymore. Beta blockers, certainly we use them a lot, and they can exacerbate Raynauds. And bromocriptine, I think it's used in Parkinson's. So some drugs can cause Raynauds as well. Here we've got someone in the blue phase after the white phase. In scleroderma, you'd have spindling here. You'd have loss of the pulp as well. You may even get little infarcts in the pulps of the fingers. What have we got here? The differentiation of Still's disease and erythema marginatum. Well, Still's is juvenile rheumatoid, and erythema marginatum is one of the rashes you can get in, I think, rheumatic fever. Now, in Still's, the rash can come on before the rheumatoid symptoms, in other words, before they get the joint swelling. Remember, if you get a macular rash and joint swelling in children, as well as Still's, consider rubella. And in Still's, it's a macular eruption. In erythema marginatum, the rash is larger and often annular. Still's disease starts worse and then gets better. I'll just look at this, because this is erythema marginatum. Curious rash, isn't it? I mean, if I was shown that picture, what would I think? I'd think that was Sweet syndrome, because of that sort of almost pseudo-blistering appearance there. Look at it. You'd really think those were big plaques of Sweets or neutrophilic dermatosis. But this picture came from Bill Land, and it's part of his collection listed as erythema marginatum. I mean, I haven't seen that rash, I just haven't seen this condition. Certainly it's larger and annular. I don't think we've got anything on Still's. This is looking at Derm Atlas, just looking down here. Well, just a quick glance just to see what they have on this condition. Yeah, there's our child with Still's into a trance. You know, it really does look measly-like, doesn't it? It's a macular, confluent macules and papules, they're saying there. Healthy 15-month-old girl, morbilliform eruption, chronic recurrent fevers. After complete medical evaluation and diagnosis, systemic juvenile rheumatoid was made. Improved with a non-steroidal anti-inflammatory. Okay, just another little picture of her here. We get a look at that. Yeah, it's tough to make a diagnosis on this. It really is. You'd initially think of a viral exanthem. You might have thought of pit rosea if there'd been any scale associated with this. You would think, even with the early joint involvement, as I say, you'd think of rubella. Go looking to see if there's lymph gland enlargement as well. Okay. What have we got? Ichthyosis and palmoplantar carotid derma. Okay, so if you've got scale and palmoplantar keratoderma, the syndromes to consider, tyrosinemia 2 and erythrokeratoderma variabilis. I'd need to look that up again. The Richter-Hanhart syndrome seems to come to mind. Erythrokeratoderma variabilis, you're going to get a variety of, well, it's red and scaly. It's usually localized in 1 or 2 areas. It's an inherited disorder. I mean, normally, say, as an acquired disorder, if I see someone with a fair bit of ichthyosis of red scale and palmoplantar keratoderma, I think of PRP. I suppose that's not quite an ichthyosis. Nails and palmoplantar keratoderma syndromes. Right, consider hydrotic ectodermal dysplasia, dyskeratosis congenita, pachyonychia congenita, and Darius. Darius, I mean, obviously the nail changes in Darius are the red and white longitudinal bands. Pachyonychia congenita is a big thick nail plate. Dyskeratosis congenita, nail dystrophy. It's not quite as distinctive. You have to look for other features. Hydrotic ectodermal dysplasia. I don't think the nails form normally. I mean, that's what usually happens in the ectodermal dysplasia. If you look and see at hair, you look at their teeth, and you look at their nails. And there's a whole variety of syndromes depending on the bits that are deficient. I always have to go and look up the books for these. The main thing is just having your eyes open so that you recognize that that might be the situation and then put it together. But the anhydrotic ectodermal dysplasia and the hydrotic ectodermal dysplasia are the 2 common ones. Purpura. If I said here, we usually think of it as either palpable or non-palpable. But from an etiological point of view, you can think of it as either being due to platelet abnormalities or vascular abnormalities. Fair enough. I mean, I'm usually concerned if I've got palpable purpura. If I have, I keep thinking it's a vasculitis. And then I check the urine to see if there's any blood in it. And if there is, I know it's part of a systemic vasculitis. But if, say, it was non-palpable purpura, then certainly check for platelet abnormalities. And usually you're going to have bruising, often it's on the upper limbs. And we're saying vascular abnormalities that can be physical, toxic, infectious, or immune. Physical are pressure, lack of support, particularly senile purpura or scurvy. Yeah, senile purpura, elderly, a lot of sun damage. They bruise so easily, and most of them are on aspirin or warfarin, so most of the bruises you're going to see there are the patients not going to have some underlying systemic disease. Scurvy, you've always got to remember. Remember that with perifollicular hemorrhages, particularly in the lower legs, and perhaps bleeding from the gums. Always go looking for that. Just see where the hemorrhage actually is. Amyloidosis. Well, remember in amyloids, you've got the amyloid protein deposited around the blood vessels, making them more fragile so they bleed easily. And so you get that panda loop around the eyes if you get hemorrhage there from rubbing, or occasionally around the anus if you've been straining to pass bowel motions. Ehlers-Danlos, usually they have marked skin elasticity. But again, it's an elastic tissue problem, so I suppose you can get vascular, easy bleeding from that. Chemicals, drugs, infection, yeah, look, palpable purpura, kid, headache, stiff neck, fever, any sign of purpura at all, it's meningococcemia. Get out a cephalosporin antibiotic and inject it into them intramuscularly. You'll probably save their life if you do that. Purpura can be immune with vasculitis, dysproteinemias, and lupus, some of the collagen diseases, causes a painful bruising. Then you've got the pigmented purpuric dermatoses, a bit of capillaritis, a bit of pressure, increased venous pressure in the lower legs with varicose veins and the like, and the back pressure causes leakage from the capillaries, little dot-like hemorrhages. Then the Hess test, God, I haven't done that for years. Get a pressure cuff, put it around the arm. I think you got to take it to about 80 millimeters of mercury, And you've got to have, if you examine an area 5 centimeters, should be more than 5 purpuric lesions if the Hess test is positive. Tells you you've got a platelet abnormality. We're all too lazy to do it nowadays. What have we got here? Okay, it's a fairly symmetrical purpuric rash. To see that that was purpuric, you'd need to put some pressure on it and see if it didn't melange. A rash like that, buttocks, you'd think of Enoch-Schonlein purpura. That's a little bit less likely. But, you know, if that's not blanching and it's palpable and it's in that distribution, then Enoch-Schonlein, the IgA-mediated vasculitis is the most likely thing. So remember, in kids, you're going to have the gut problems, you're going to have the kidney problems associated, or you may have kidney problems associated with that condition. Occasionally even melena from, and you may have some arthritis as well. Those are the things: arthritis, gut, and kidney for Enoch-Schonlein. Do a biopsy and some immunofluorescence for the IgA. What are we ending up with? Ignitus. Lupus, the other name for it is lupus miliaris disseminatus faciei. And it used to be thought of as being a tuberculid. It may just be a form of granulomatous rosacea. There's a scar-like lesion, particularly on the forehead, with brownish pigmentation and sometimes some yellow in the middle of it. All right, it's these lesions up here, often at the edge, the scalp edge, ignitus. Sometimes they break down like this as well. It's not that they're scratched. Usually you need a biopsy. I still think of it more likely as being a form of granulomatous rosacea, and when I see it I treat it with oral tetracyclines and a bit of sulfentrazole. What have we got to finish up with? Compare granulomannulari and sarcoidosis. Well, GA is more likely to be at sites of trauma, so back of the hands, knees, elbows, dorsal of the feet. They're both obviously dermal processes. There's no epidermal component. Colors can vary. GA can be skin colored all the way through to a purple sort of color. And sarcoid's always your differential diagnosis of it. GA is made up of indurated papules. Sarcoid again begins as papules, but they're a different color. Okay. This fusion of the papules. Both these lesions, though, will give a crust on the surface when they perforate. Yeah, look, it's rare, but you do get perforating granuloma annulari, and you can get perforating sarcoidosis. Then disseminated GA, this is where you get it all over the body surface, often as small papules. This can last 3 to 4 years, and certainly there the differential diagnosis is sarcoid. But they've also IDT, a lichen planus, and lymphoma. Well, you do a biopsy. You really need to get histological confirmation. Sometimes it can be annular in other areas, such as the back of the hands. Well, that's sarcoid we're talking about there. And sarcoid's often annular on the face, and it's often annular on the genitals. Usually disseminated granulomannulari is papular. Compare lichen scrophulosaurum and lichen nitidus. Well, lichen scrophulosaurum again is one of these tuberculids. It's usually seen around the elbows and knees, localized patch, scaly, small, very small punctate papules. Lichen nitidus, micropapules. Younger patients, I think. Let's have a quick look at this example of lichen nitidus. What do we got? Let's look at this one here from Global Skin Atlas. Let's view this full size. Okay. Here you can see the grouped micropapules of lichen nitidus. That, see that there? That appears to be the Kobner reaction. In other words, with scratching, the lesions are coming out in that line. Now, you might have looked at that and said, oh, you got warts. Well, you get a lot of warts, but you can get the Kobner effect with warts as well. But this these are the group micropapules of lichen nitidus. Very characteristic histology. Lovely one that they like to show you in the exams, just because of the claw-like extensions of the epidermis around the granulomas. It's a very, very distinctive picture. What looks like granulomas, but it's a lichenoid infiltrate that you're in fact going to see. Let's flick this back. Lichen scrophulosaurum usually is quite rough because it has keratosis spindulosa. That's right, it's more spiny-like. Whereas lichen nitidus is more monomorphic and smooth. So, lichen scrophulosaurum, elbows and knees, a tuberculid, keratotic, because it has a keratosis spinulosa-like pattern, whereas lichen nitidus more monomorphic and smooth. And the last thing we've mentioned there is leptospirosis. In conditions due to a spirochete give jaundice and necrotic lesions in the skin. Can't say that I've seen a case of leptospirosis before. If you're going to see it, I think you're more likely to see it in vets than anyone else. But occasionally you'll get this if some people have been overseas and say they've been swimming in water that's infected with leptospira. But if you see them back with curious papular urticarial, itchy papular urticarial-like lesions and they've been overseas and they've been swimming, then the other thing to think about is schistosomiasis. That there's been wee larvae of schistosoma in there that have in fact got into the skin, and that's what they're reacting to. But vets, certainly a vet comes in with a bit of jaundice and necrotic lesions in the skin, consider leptospirosis. Okay, this was just a quick run through some unusual conditions and some comments that Ken Paver had made many years ago. I hope you enjoyed it. Bye-bye.